Chapter 21, The Normal Newborn Assessment. Initial assessment of the newborn is more in-depth than what will be done during the normal shift assessments. This initial assessment provides us with a baseline of data so we can monitor for changes. We'll discuss exactly what you will do as far as your shift assessment when we have lab or your clinical rotation. Cardiorespiratory status is a crucial assessment to perform. Airway is going to be a concern. Airway can be compromised from fetal lung fluid that has not been expelled, mucus in the airway, or structural abnormalities. The normal respiratory rate is 30 to 60 beats per minute. You must take into consideration what the infant is doing. If they're crying, a higher rate may be present. Newborn respirations are considered to be irregular. You will note that they breathe very fast for about 10 to 15 seconds, and then you may see a period of up to 10 seconds with pauses in breathing. This is known as periodic breathing, so for our newborns, it's crucial to count respirations for a full minute. Apnea is considered for pauses in breathing lasting 20 seconds or more, or any pause with cyanosis, pallor, bradycardia, or decreased muscle tone. Breath sounds will be assessed, and it's not uncommon to have scattered crackles for a period after birth. These are more common in the C-section babies, ones that are delivered very quickly, as that is not absorbed and they do not receive the squeeze during that vaginal delivery that will help expel the fluid. Assessing the respiratory distress is an ongoing assessment. Signs of respiratory distress include tachypnea, retractions, nasal flaring, cyanosis, and grunting. Retractions in an infant is comparable to an adult using their accessory muscles. Mild, occasional retractions after birth are normal but should not continue past the first hour of life or have other symptoms of distress noted. Choanal atresia is the blockage or narrowing of one or both nasal passages by bone or tissue. Newborns are nose breathers, so this blockage can cause an infant to display signs of distress. To assess, the nurse will close the mouth and block one nair at a time and listen to breath sounds during the time it's occluded. Color is assessed as well. Acrocyanosis is when the infant's hands and feet are bluish purple in color, and this is a normal finding. This is due to the blood being shunted to the vital organs instead of the extremities. This is another teaching you can provide to parents as they think the infant is cold or it's abnormal. Cyanosis is not normal and should be reported to the provider. Some newborns will have pallor, which can indicate slight hypoxia or anemia. A CBC can be obtained to determine any issues. Ruddy is a red color. The infant can indicate polycythemia. Brachial and femoral pulses are assessed bilaterally and noted for quality and presence. Rates are not obtained for these sites. To get a heart rate, an apical pulse will be obtained for a full minute. Normal rate is 120 to 160 during normal activity. It can increase to 180 during crying and can decrease to 100 during periods of deep sleep. Assessments for murmurs is also done at this time. Blood pressures are not needed and a non-complicated delivery with no abnormalities found. The average for a full-term infant is 65 to 95 systolic and 30 to 60 diastolic. Many times if they are checking blood pressure, they will check on all four extremities to rule out coarctation of the aorta, which is a congenital heart disease. This can be indicated by more than 20 millimeters of mercury difference between the upper and lower extremities. We already talked about the importance of thermal regulation in the newborn, so we'll discuss the norms and how we do it. The temp should be obtained shortly after delivery. This is done using a thermometer, or if the newborn remains under the radiant warmer, there's a probe that's placed on the infant's abdomen and recorded. This method is used more frequently if the infant is cold and having a harder time maintaining their temp, or if the infant who is having complications and remains under the warmer for frequent monitoring. You will see the warmers during clinical. Normal method of obtaining the temp is axillary, and the normal readings for axillary is 97.7 to 99.5. Facilities can have their own protocols for the norms they like, but these are general guidelines. Remember, a low temp in an infant can indicate sepsis, so a low finding is just as bad as a high finding. Rectal temps are not standard of care in the newborn that is not showing any signs of complications due to the risk of anal perforation. The rectal temps are more accurate as it measures core temp, and if an infant is having issues with thermal regulation, a rectal temp may be obtained. When we're doing our assessment, we're looking for any anomalies. When assessing the head, you will notice it's large in proportion to the rest of the body. Looking at the scalp for any abnormalities, you'll palpate and look at the head for the shape. Molding is a change of the head to fit through the birth canal. It can make the infant look like a cone head. It should resolve within the first week of life. The head is made up of suture lines where the bones are located. Overriding sutures is when, as a head needs to mold to fit through the birth canal, the bones can overlap each other. When palpating overriding sutures, it feels like there's a ridge. This is hard to explain what it feels like, but once you palpate it on a newborn, you will understand. You can also palpate and document the anterior and posterior fontanelles. The fontanelles are the areas where the sutures meet. The anterior one is diamond-shaped and is located where the frontal and parietal bones meet. This closes by age 18 months. The posterior one is triangular in shape and located where the occipital and parietal bones meet. It's much smaller and closes by 2 to 4 months. When assessing, you determine if they are present, which is known as open, are they flat, which is normal, or are they depressed, which could indicate dehydration, or are they bulging, which could indicate increased intracranial pressure when the infant is quiet. Crying can cause a bulging fontanelle as well. Caput succedaneum, or typically called a caput, is an area of localized edema as a result of pressure of the head against mom's cervix during labor and delivery. The area does the area does cross the suture line of the head, meaning it's not just on one side of the head, and it's soft. It varies in size and can occur when a vacuum is needed to assist during delivery. It will disappear within several days of birth. A cephalohematoma results from bleeding between the periosteum and the skull caused by pressure during birth. It can occur on one side or both sides and typically is not present right at birth but will develop within the first 2 days of life. The main difference between the caput and the cephalohematoma is the caput does cross that suture line and the cephalohematoma does not. The cephalohematoma will absorb slowly and can take a few months to fully be reabsorbed. Because of the breakdown of the RBCs in the cephalohematoma, this infant is higher risk for jaundice. We assess the neck to be sure the infant can move it from side to side, and we look for any webbing. Clavicles are palpated for any dislocation. The presence of any swelling, lump, tenderness, or crepitus can indicate a fracture and needs to be reported to the provider. The umbilical cord should be noted for 3 vessels, which include 2 arteries and 1 vein. A 2-vessel cord, which is 1 artery and 1 vein, could indicate a chromosomal defect or renal defects. When assessing the extremities, you look for movement of all 4 in a random manner. Poor muscle tone can cause the newborn to appear floppy or limp. When looking at hands, look for all digits are present, no extra digits are present. Look for any webbing of the fingers. The hands are assessed for a single transverse palmar crease that is parallel with the base of the fingers that crosses the palm without a break. This is referred to as the Siamean crease and can be a sign of Down syndrome if paired with incurving of the little fingers and low-set thumbs. Normally, the newborn will have 2 long transverse creases that extend most of the way across the palm. The feet are assessed for extra or missing digits and for webbing of the toes. Assessed for club foot, which is where the foot or feet will turn inward. Hips are assessed for developmental dysplasia, which we'll talk about more in upcoming weeks. This is done by the Ortolanti and Barlow methods. Figure 21.11 shows how these are performed, and we'll talk more about these in lab. The vertebral column is assessed by running hand over it and palpating for any defects. You also look at the base of the spine for an indentation and tuft of hair, which can be signs of spina bifida, which is a neural tube defect. Other types of neural tube defects include a meningeocele, which is a protrusion of spinal fluid and meninges, or a myelomeningeocele, which is a protrusion of the spinal fluid, meninges, and the spinal cord through the vertebrae. Measurements taken at birth include weight, length, head, and chest circumference. The baseline data is needed to monitor growth. One of the main ways we assess neurostatus in the newborn is by their reflexes. Table 21.3 will show these. The ones we will be concerned about are the Moro, Palmer, Planter, Babinski, rooting, and sucking. An absence in reflexes can indicate serious neurological problems. Diminished response can mean an ill child. Please review in the book the reflexes that I mentioned, and I will go over how to do these in class and answer any questions you may have. Ears are assessed for placement, overall appearance, and maturity. The top of the ear should be even with the eyes. Low-set ears can be an indication of chromosomal abnormalities, especially Down syndrome. The more premature an infant is, the less cartilage they have. This is the part of the preterm infant assessment that we'll talk about. A hearing test will be performed on all newborns before discharge. Eyes are assessed for any abnormalities, signs of inflammation, and any discharge that is noted. All newborns should be treated with prophylactic antibiotic cream to decrease the risk of infection that can occur during delivery. This is especially true for bacteria from maternal gonorrhea, which can lead to blindness. Other signs we will assess for in the neurological system is for any tremors or jitteriness. This could be a sign of hypoglycemia, hypocalcemia, or prenatal drug exposure. Any seizure activity would be noted and reported for further evaluation. The pitch of a cry is another area we assess. A high-pitched cry or a shrill can indicate neurological disorder or other problems, so it needs to be reported to the provider. Increased irritability can also mean neurological disorders or signs of drug withdrawal. The main assessment of the hepatic system include blood glucose and bilirubin monitoring. We've discussed both of these before, so please review, and I will add a few things here. Please see box 21.4 for risk factors for hypoglycemia and the safety alert box next to it for signs of the hypoglycemia. When a blood glucose level needs to be checked, it's typically done via a heel puncture. Just like an adult, if the level is below or above protocol, they will get a lab draw to verify. There is a procedure box in your book on page 449 about heel sticks. Please review this so you know the proper area on the foot to use. This is very important so you do not cause nerve damage. Please review box 21.5 for risk factors for hyperbilirubinemia. The assessment of the GI includes mouth, suck, initial feeding, abdomen, and stools. We'll go over these more in depth during your lab as far as how to do all the assessments. You will check the mouth for an intact palate to determine if there's a cleft palate or lip. You can do this by putting on a gloved finger in the mouth and feeling and looking. You can also look for any teeth that could be present at birth. Complete the suck reflex by having the infant suck on your gloved finger. The initial feeding should take place shortly after birth. This is when the infant is alert, which makes feeding easier. The abdominal assessment includes looking at the abdomen for any abnormalities as far as hernias, mass, etc. You're going to palpate. The abdomen should be soft and many times slightly rounded. Listen for bowel sounds as well. Note the first stool as far as the amount and characteristics. GU assessment includes noting the first urine, also assessing the genitalia. Look for any abnormalities. If the female edema and whitish discharge, in the female edema and the whitish discharge is normal. In the male, feel to be sure that both testes are descended. The meatus should be at the top of the penis. If it's underneath, this is known as hypospadias, and it's above, it's an epispadias. Your book does a nice job showing pictures of different integumentary assessments. I'm going to go over a few of these. Vernix caseosa, known as vernix, is the thick white substance that resembles cream cheese. This provides protective covering for the fetal skin and utero. Typically, the more preterm the infant is, the more vernix they will have. Lanugo is a soft, fine hair that covers the fetus. The more preterm, the more lanugo. Milia are white, small cysts that can occur on the face and forehead. They are harmless and will disappear within the first week. Erythema toxicum is known as a newborn rash. It's harmless and will disappear within hours or days. Most of the time with the use of ultrasounds, we know the correct gestation of a newborn, but in cases when mom did not receive prenatal care, a Ballard score may be performed. Your book is a copy of this tool. You will not be responsible for doing the Ballard assessment, but there are a few areas that I want you to be familiar with as they are pretty general in all newborns. We talked about the vernix and the lanugo already. Another area they look at are the soles of the feet. Absence of plantar creases means a preterm infant. Please look at the pictures in your book regarding doing the assessment. Babies can be classified by their appropriateness by plotting the gestational age and their weight, length, and head circumference. There are charts that will determine if they are small for gestational age, which is SGA, AGA, which is appropriate for gestational age, or LGA, which is large for gestational age. To be classified as SGA, they are below the 10th percentile of all other infants with the same age, weight, length, and head circumference. The LGA are classified by above the 90th percentile of all newborns with that criteria, and the AGA are all the infants between the 10 and 90 percentile for that criteria. In upcoming weeks, we'll talk more about the significance of these findings.